We are live now.
Good evening, everyone. I am Dr. Maunika, medical advisor from Shield Healthcare. And I welcome you all for today's session. And I welcome our speaker, Dr. Chaitanya Deepak. He's the director and consultant psychiatrist, Asha Hospital Institute of Medical Psychology, Counseling and Psychotherapy. And today's topic is OCD and neuromodulation. I welcome you, sir, and I hand over the session to you.
Thank you. Let me share my screen. Yeah, my screen is visible, right?
Yes, sir, it is visible.
Yeah, okay. Good evening, everybody. Dr. Chaitanya. Today we are going to talk about briefly about OCD, its signs and symptoms, and various other clinical features, and go a little bit in depth about neuromodulation. So OCD is a disabling psychiatric condition that affects around 2% of the population. It is characterized by both obsessions and compulsions, or either of them. Obsessions are persistent, unwanted thoughts or images that cause distress and anxiety, whereas compulsions are repetitive behaviors or mental rituals that are aimed to neutralize the distress and anxiety. So, as I was telling, it has a lifetime prevalence around 2 to 3%, and it usually affects at an average age of 35, with onset as early as 10 years. And women are more affected than men. And the comorbidities can be depression, phobias, and panic disorders. So, not very long back, OCD was a part of anxiety spectrum disorders. Now it gained an independent identity both in the DSM as well as ICD. In DSM-5, the major changes for OCD is the fact that it and its related disorders have their own chapters and no longer considered as an anxiety disorder, and similarly in ICD-11. These are the other OCD spectrum disorders that are grouped together. So some of the features of obsessions are like intrusiveness, ego dystonicity, neutralizing behaviors, subjective resistance, unacceptability, and uncontrollability. Whereas features of compulsions would be repetitive stereotypic and intentional behaviors, which diminish sense of voluntary control, prevention or reduction of distress or related consequences, consider exaggerated urge to perform. So there are various causal factors for OCD, such as psychosocial, cognitive, biological, behavioral, and genetic factors. In biological factors, coming to neurotransmitters, serotonin is one of the most important neurotransmitter that has been implicated in causal of OCD. Glutamate also is one of the neurotransmitters that is hypothesized to be causal of OCD. And coming to neuroimmunology, the pandas, that is streptococcal A hemolytic infections, are one of the developed in childhood, is proposed to be causal of OCD in adulthood. And coming to genetics, family studies and twin studies and adoption studies and all have proven that there is genetic predisposition for OCD, and this genes and chromosomes have been implicated in causal of OCD. And coming to neurobiology and brain circuitry, the corticostriato-thalamocortical circuit is one of the most important circuits that is implicated in OCD. The OCD pathophysiology provides dysfunction in several distinct overlapping brain circuits involving connections from cortex to basal ganglia to thalamus and reciprocally back to cortex, known as corticostriato-thalamocortical loop. In various brain imaging studies have shown that there is decreased gray matter in dorsolateral prefrontal cortex, anterior cingulate cortex, inferior frontal gyrus, and anterior insula, and absence of age-related changes in putamen, insula, and OFC. Basal ganglia is one of the most important structure that is implicated in OCD. Scientists propose that any damage to basal ganglia might result in OCD symptoms. The significance of identifying the basal ganglia is that it shows physical damage to a brain structure results in neuropsychological condition. OFC and ACC are intricately connected to basal ganglia by cortico-basal ganglio-thalamocortical loops. CT and MRS studies have shown that there is a decrease in size of caudate nucleus bilaterally, and PET scans show increased activity in frontal lobe, caudate nucleus, and cingulum. The caudate nucleus specific brain cells in basal ganglia, the area of brain acts as a filter of thoughts coming in from other areas. The caudate nucleus is also considered to be important in managing habitual and repetitive behaviors. The prefrontal orbital cortex located in frontal area of the brain. The level of activity in prefrontal orbital cortex is believed to be affected appropriate social behavior. Lower activity or damage in this region is linked to feeling uninhibited, making bad judgments, and feeling of lack of guilt. More activity may therefore cause more worry about social concerns. And role of cingulate gyrus is believed to contribute the emotional response of obsession. This area of the brain tells you to perform compulsions to relieve anxiety. This region is highly interconnected to the prefrontal orbital cortex, basal ganglia by a number of brain cell pathways. This is the thalamocorticothalamic pathway, cortex to striatum to globus pallidus to thalamus, and to globus pallidus externus in subthalamic nucleus through glutaminergic and GABAergic neurotransmitters. Coming to management of OCD, the first line treatment of OCD is like cognitive behavior therapy with specifically ERP, that is exposure and response prevention, and next is pharmacotherapy, which is made primarily by SSRIs, and also in addition to SSRIs, adjuvant therapies like TCS and augmentation with neuroleptics can be used, and like risperidone and epiprazole, and somatic therapies like neuromodulation. So our focus for today is going to be mainly neuromodulation. Neuromodulation is target specific brain circuits that are important in pathogenesis of OCD. Neuromodulation therapies have minimal side effects and minimal drug interaction, if at all. The International Neuromodulation Society defines neuromodulation as a field of science, medicine, or bioengineering that encompasses implantable and non-implantable technologies, electric or chemical, for the purpose of improving quality of life and functioning of humans. It involves the process such as inhibition, stimulation, modification, regulation, or therapeutic alteration of activity of neurons in central, peripheral, or automatic systems, chemically or electrically. Neuromodulation is basically non-destructive, adjustable, and reversible. The most common neuromodulation that has been used since ages in psychiatry is ECT. And of late, we have TMS, which is transcranial magnetic stimulation. Neuromodulation approaches can be either ECT, like conventional like ECTs, or the newer techniques like transcranial magnetic stimulation, transcranial direct stimulation, TDCS, alternating current stimulation like ACS, and deep brain stimulation as in DBS. The clinical efficacy in TMS, there are two types, which is like the regular RTMS and deep TMS. So deep TMS has a lot of higher penetration than the regular RTMS, and we are going to see a little bit in depth about the deep TMS techniques and what is the difference between the regular RTMS and deep TMS. Advantages of neuromodulation is neuromodulation devices and treatments are life-changing, and the neuromodulation therapy targets specific brain circuits. Brain stimulation modulates system endogenous response, allows the system to recruit adaptive strategies and minimum side effects and drug interactions. So neuromodulation techniques can be non-invasive, divided into non-invasive techniques and invasive. Under invasive, it is intracranial and peripheral, as in DBS and other techniques, and vagal nerve stimulation and cortical stimulation. In non-invasive transcranial techniques, there is direct and indirect. Direct electrical, which is ECT, and other non-convulsives like TDCS. And in indirect, it is magnetic, which is as in RTMS. So coming to deep TMS technology, basic coil design is H coil. So that allows much higher penetration of the magnetic waves. The magnetic fields pass through tissues more readily with less interference, which in turn generates electric currents in brain tissues. Coils arranged in specific geometry, tangential and parallel to target brain areas, assumed to modulate neural activity. Convergence of electrical pulses from various directions is possible. The coil designs are specific to stimulate specific brain areas. So this is a H coil design. You can see over here. The complex architecture of the coils, characteristic current flow directions, magnetic field generated in greater strengths and gains, a direction into deeper brain areas. Induced currents activate neurons which are in parallel to the electrical lines. Trade-off between depth and focality. Deeper neuromodulation has better clinical outcome. With different coil configurations, one can achieve different depths and focality. Figure of 8 coils, focus stimulation but superficial. Butterfly coils are deeper but less focused. And both of them are achieved through the H coils. Any possibility for deeper as well as focus stimulation is through H coils. H coils with complicated loop and line architectures makes this possible. Different shapes of the coil induce neuromodulation at different depths and volumes of the brain, as it is depicted in the image below. We have like different coils like butterfly coil, H coil, halo figure of 8 coil, planar figure of 8 coil, and various areas can be targeted, and various depths of the brain can be targeted with each of these coils. H coil in the brainsphere helmet induces direct neuromodulation in deeper brain areas, which are primarily under the coil as well as the distant brain areas. As you can see in the image depicted over here, the penetration is much larger than the regular figure of 8 coil or planar coils. Same is like depicted in this picture. Figure of 8 coils have like maximum penetration of up to like 2 or 3 centimeters, whereas deep coils have a penetration of about 5 to 8 centimeters. So deep TMS ensures that the target area is definitively covered under the magnetic field. Deeper and wider target area stimulation in many disease conditions is possible with this deep TMS. Like in DLPFC with left preference in MDT. Focal stimulation in few special disease conditions is also possible with deep TMS, like in auditory hallucinations. Just a comparison between the double cone coil and the H coil. This is the neuroimaging where it shows the colored field maps for the H7 coil, indicating the absolute magnitude electric field in each pixel at 100% of foot motor threshold for 14 coronal slices 1 cm. Red pixels indicate regions with field intensity above the threshold for neural activation. This like shows how deep it can penetrate and how activating it is. Different coil designs target different areas like H7, H1, and H4 coils. Each coil is designed to specifically target specific areas for various health conditions. And of the various coils available, 3 of these H coils are approved by the US FDA. The H coil elements are tangential to the head and close to the target brain regions. The flexible base suited to head shape, convergence of numerous electrical pulses from various directions, and the coil elements are parallel to target bundles. Location of return paths of electrical impulses remote from the target areas. thereby reducing the hindrances. Coming to H1 coil, it is cleared by FDA for treatment of major depressive disorder in 2013. It is a unique 16-week double-blind. It was approved from the findings of a unique 16-week double-blind placebo-controlled multi-center study, which enrolled over 200 subjects and reported a marked decline in HTRS 21 scores, as well as significant remission and response rates at the primary endpoint of study after 4 weeks of acute treatment. H1 coil is also in clinical trials at various stages for treatment of bipolar, PTSD, and schizophrenia. These are the various other indications which are not yet approved by the FDA. And this H1 coil has like showed clinically significant and statistically significant improvement in major depressive disorders. And coming to OCD, the H7 coil is specific for OCD, and it has been cleared by FDA for treatment of OCD. And various trials have been conducted for the same, and it has been statistically been proven that it is quite effective in treating OCD and reduction in symptoms. The BrainsWay H7 coil specifically designed to treat the anterior cingulate cortex is the only TMS platform cleared by FDA for this purpose. As it is seen over here with deep TMS and sham, the comparison, it is statistically significant. There is significant reduction in Y-box scores. And the response that has been achieved is also quite well sustained even after the end of the treatment. And the H4 coil is for smoking cessation. It has also been cleared by the FDA for treatment in nicotine dependence. BrainsWay H7 coil specifically designed to treat anterior cingulate cortex is the only TMS technology for this purpose. So as you can see over here, comparison between sham and deep TMS, the quite a significant, statistically significant improvement in deep TMS arm with cessation of smoking, which is also quite sustained even after treatment. So why do we need H coils? H coil versus standard figure of 8 coils, there is greater activation. The electrical field induced activation of a larger volume of gray matter, shortest clinically proven treatment, reliable targeting, bypassing the complex neuronavigation procedures as in other figure of 8 coils, consistent activation of target areas. These are the advantages of the H coil over the figure of 8 coil. So I was telling, deep TMS has a better penetration. It is extensive, more reliable targeting, deep and broad, cleared for multiple large markets. Advantages of the deep TMS are deeper, broader stimulation, non-invasively, strength of stimulation to be maintained at effective levels, even in regions deeper to the brain, which otherwise are not usually approachable by the other coils in TMS. Late-light diffraction, cortical atrophy, deeper stimulation is required. This also can be achieved. When scalp cortex distance is increased, deep TMS will prove efficient, reduces the likelihood of targeting errors. And deep TMS is also been indicated for various neurological disorders such as Parkinson's, tics, dystonia, neuropathic pain, and stroke rehabilitation. And coming to other neuromodulation techniques, one other popular thing is transcranial direct stimulation. TDCS is the non-invasive neuromodulation strategy used in OCD as well as hallucinations. It is a weak direct current conducted across brain between two electrodes. Cathodic stimulation is thought to be inhibitory, while annular stimulation is thought to have excitatory effects. Typical stimulation parameters are 1 to 2 milliamps delivered for 20 to 30 minutes, and patients typically undergo repeated treatments for 10 to 20 treatment sessions. The target selected pre-SMA and SMA and medial prefrontal cortex, DLPFC and OFC. The small device is very portable and usually operated by readily available DC batteries. This is a TDCS device, and the picture adjacent to that shows how it is applied to the brain. And most of the times, even the family members or the patient himself can administer this treatment once trained appropriately. Transcranial direct current stimulation is a non-invasive neuromodulator technique that delivers, as I was telling, 1 to 2 milliamps of current to the cortical areas through application of electrodes on the scalp, facilitating or inhibiting spontaneous neural activity. The direct current polarizes current, and TDCS is believed to act via the alternation of neural membrane polarization. Polarization may affect the firing and conductance of neurons by either lowering or raising the threshold of activation. TDCS involves application of low currents to scalp by cathodal and anodal electrodes, depending on the direction of the current flow. Polarization can either inhibit or facilitate the function. Anodal stimulation showed significant improvement in therapeutic safety learning. Coming to OCD and TDCS, TDCS could potentially elevate OCD symptoms by modulating activity of OFC or DLPFC. Interestingly, using functional imaging, they showed that functional connectivity increased between frontal pole and the middle and superior frontal gyri. They found that functional connectivity between the insula and basal ganglia decreased, and as did the functional connectivity between dorsolateral nucleus and ciliaris networks. Overall, these studies all showed feasibility and efficacy of TDCS in targeting multiple brain regions. TDCS is an efficacious and non-invasive neuromodulation modality that extends the armamentarium of treatment of refractory OCD. It is not approved by FDA in treating OCD as of yet. And coming to invasive neuromodulation techniques, mainly it is deep brain stimulation and vagal nerve stimulation. Ablative techniques have largely been replaced by neuromodulation, like ablation techniques like capsulotomy, cingulotomy, and all those things. As the only FDA-approved form of invasive neuromodulation for OCD, DBS utilizes pushed electricity at a specified pulse width, voltage, and frequency to modulate the activity of deep target structures. DBS has been used for treatment of various other disorders like movement disorders and all. Increased interest in using DBS for OCD. DBS works to directly modulate the known networks continuously over longer timescales. Invasive procedure, the risk of operation is small and reversible in nature. Treatment can be optimized post-operatively. Implanting deep brain stimulator. The patient undergoes an MRI which precisely maps out the target areas of the brain to be treated. An incision is made in the scalp. The electrodes are precisely inserted through the burr holes and into the target areas of the brain. Two wires are threaded behind the ears down to the neck to the pulse generator, which is usually implanted near the clavicle, which is depicted over here in the picture. The most common targets for DBS in OCD include the anterior limb of the internal capsule, nucleus accumbens, bed nucleus of stria terminalis, and subthalamic nucleus, inferior thalamic peduncle. In 2014, the Congress of Neurological Surgeons and American Society of Stereotactic and Functional Neurosurgeons released guidelines for DBS in OCD. Only level 1 evidence to support bilateral ST and DBS over medical management in treatment refractory OCD. The World Society of Stereotactic and Functional Neurosurgeons published consensus guidelines for DBS and OCD. Coming to vagal nerve stimulation is an alternative modality of brain stimulation which has been approved for treatment-resistant epilepsy and treatment-resistant depression. Vagal nerve stimulation typically involves placement of electrodes around the cervical portion of the left vagus nerve with stimulation delivered in an intermittent but chronic manner. Through stimulation of these cranial nerves, VNS indirectly modulates the activity of brain networks and has the potential to induce changes in cortical connectivity and excitability. The use of VNS in psychiatry has been largely confined to TRD, and its efficacy in other psychiatric disorders has been less widely studied. So finally, to conclude, OC is a chronic debilitating psychiatric disorder which around a prevalence of 2%. SSRIs and CBT is the first line of therapy. Neuromodulation and surgical methods may be tried in carefully selected patients with treatment refractory or severe OCDs. RTMS and DVS is approved for OCD by FDA. ECT has limited use in OCD with low efficacy and more adverse events. TMS and other forms of magnetic stimulation hold a tremendous promise in psychiatric treatment due to their focality and non-invasiveness. Thank you.
Sir, thank you for your presentation, sir. We do have certain questions from our audience. Shall I read it out, sir?
Yeah.
One question is, in addition to current therapeutic option and surgeries with coil, do you see the role of probiotics management of cognition, anxiety, and depression in MDT, as some of strains found to stimulate vagus nerve?
Probiotics, few of them are already in the market, which are useful, and some studies have shown that they help in reducing depression as well as anxiety. In OCD, not many studies are there, but definitely for depression and anxiety, probiotics have been shown to be having a positive effect.
And sir, another question. Sir, what is the procedure for patient assessment prior to deep brain stimulation?
First of all, the treatment resistance should be proven like any other stereotactic surgery. They must have had a minimum trial of two groups of drugs which proved to be not effective for the patient, and other non-pharmacological methods like cognitive behavior therapy and other non-invasive modalities have been already tried, and not much of improvement was seen in the patient. That is the first criteria, so that the patient is suited to go through the procedure. And then the fitness for undergoing the surgery and other things would be determined by the neurosurgeon.
I think so. We have only two questions for now, sir.
Okay.
Yes, sir. We have only two questions for now.
Okay.
And thank you so much for your time, sir. Thank you for your valuable information which you have shared in this session. I hope we do a lot of information session like this. And thank you so much, sir.
Thank you.
And sir, we do have a question again.
Okay.
And the one who has asked regarding probiotics, if it is recommended, what is the dose and duration of probiotics would you recommend for such patients?
The duration for probiotics is not specific. It can be given based on symptomatic improvement of the patient. There are no guidelines as such for how long they should be used.
Yes, sir. I hope the one who have asked this question, they got the answer. Thank you so much, sir. With your permission, shall we close the session?
Thank you.
Thank you, sir.